Imagine a 52-year-old patient walking out of a neighborhood clinic in Bengaluru. He's experiencing persistent chest discomfort, and the doctor has just handed him a piece of paper stating he needs to see a cardiologist. Before he even reaches his house, a dozen logistical questions hit him. Which hospital should he go to? Is a specialist available today? Will his insurance cover it? Must he carry old ECG reports? This analog confusion persists despite India's massive digital health infrastructure. Between the Ayushman Bharat digital mission and national platforms like eSanjeevani, hundreds of millions of health records and IDs are already digitized. In fact, Karnataka itself has an active online referral system. Doctors and local clinics are already using software to generate these referrals. The friction point exists because our current systems digitize the document but leave the care journey itself in a void. Real success requires the patient to reach the right specialist, receive care, and have the outcome reported back to the original doctor. To find where patients disappear, we can look at a 2025 World Health Organization case study analyzing Karnataka's digital referral data. Mapping the operational data reveals a massive gap. Out of 10,000 referrals generated by clinics, only about 3,000 linked back to the claims database. The remaining 7,000 patients become invisible to tracking tools the moment they walk out the door. When referrals definitively break down, the operational data tells us the primary cause. In over 61% of recorded cases in Karnataka, the referral failed because a specialist was unavailable when the patient arrived at the hospital. Digitized letters fail here because the system lacks a mechanism to assign explicit ownership over the transition between the clinic and the hospital. Without a comprehensive map of who is available and where, doctors navigate this blind spot manually. They rely on personal networks, calling former classmates to find an available specialist for their patient. This flowchart shows the current process. Dr. A creates the referral, hands it to the patient, and the patient carries that request into the unknown. This forces a sick individual to act as a medical courier, physically transporting CDs of scans and handwritten prescriptions. Even when treatment occurs, the information loop remains open. Dr. A never receives the medical outcome. The truth is, India's urban centers have the necessary medical providers. The system simply lacks an orchestration layer to connect them. Solving this requires a care continuity operating system, a platform that manages the medical journey rather than just issuing a document. Applying state-machine logic creates a trackable life cycle with sequential checkpoints, from initial request to final counter-referral. The software matches medical needs against real-time specialist availability. A digital referral passport allows clinical context to travel independently, removing the data transfer burden from the patient. By identifying an available specialist at the point of care, the technology handles the logistical heavy lifting of navigation. This architecture is supported by a navigator, a receptionist or coordinator who oversees these transitions. The software highlights the exceptions, alerting the navigator only when a referral stalls, for instance, if an urgent appointment isn't booked within 48 hours. Medical responsibility must extend beyond the walls of the initial consultation. By redesigning the connection between providers, we ensure the care journey stays active until the medical issue is resolved. This turns the referral into a functioning pathway for the patient.